So, very good morning, everyone. Hope you are doing well. In today's session, I'm going to cover the management of glycemic control in patients with cancer, and this is the guidance from the for the oncology and diabetes multidisciplinary teams. It was published in the Joint British Diabetic Society as a guidelines in January 2023. This is an extremely important set of guidelines for exam purposes as well as in clinical practice. In fact, in the last 3 years of SCE exams, at least 3 to 4 questions has been asked from this set of guidelines. So this is also my lecture number 90 of my lecture series, which covers the whole spectrum for endocrinology exams as well as clinical practice. So let's start right away. So a bit of introduction, what we are going to talk about in this lecture. We are going to discuss about 6 case-based scenarios, which will help the endocrinology, oncology, and the hematology teams on managing the glycemic control in patients with pre-existing diabetes, or those at risk of developing diabetes or hyperglycemia, or those who have a new onset of diabetes during anti-cancer treatments like chemotherapy, like targeted therapy, like steroids, and immunotherapy for that matter. Of course, it's primarily intended to cover the whole spectrum of clinics which deal with these spectrum, and it will be useful for inpatient as well as outpatient. So a quick overview of some of the common anti-cancer drugs which are associated with risk of diabetes and hyperglycemia. So here we are talking about systemic anti-cancer therapy or SACT. To remember targeted therapy, this includes mTOR inhibitors, EGFR inhibitors, P13K inhibitors, multi-kinase inhibitors, tyrosine kinase inhibitors, which is one of the exam favorites, especially nilotinib and ponatinib. Both have been asked in the previous exams, having a risk of developing type 2 diabetes. mTOR inhibitor, especially everolimus, has been asked in the previous exams, almost 12 to 50% risk of developing diabetes. In terms of the monoclonal antibodies, again, gemtuzumab, which is anti-CD33, 10% risk of developing diabetes, again, has been asked in the previous exam. And especially look at ALK inhibitor like ceritinib, which has a 49% risk of developing diabetes or hyperglycemia, again, has been asked in the previous exams. One point to note here is also of somatostatin analogs, which are useful for neuroendocrine tumors like octreotide and lanreotide. They have up to 30% risk of developing diabetes, and we'll also see how it can cause hypoglycemia in one of the case scenarios, which we'll discuss in the next slides. Chemotherapy targets antimetabolites, so 5-fluorouracil, pemetrexed, and decitardin all have a risk of developing type 2 diabetes. Alkylating agents, platinum-based, anthracyclines, all of these carry a risk of diabetes, especially busulfan has been asked in the previous exams, carrying almost a risk of 66 to 67% risk of developing diabetes or hyperglycemia. Immune checkpoint inhibitors, a favorite for the exams, and I have a full lecture on immune checkpoint inhibitors and their endocrinopathies, extremely set of guidelines and lecture for the exams and clinical practice. Here we are looking at PD-1 inhibitors like nivolumab and pembrolizumab. Both have been asked in the previous exams. And CTLA-4 inhibitors like ipilimumab and combination therapy as well, all having a risk of type 1 diabetes, causes insulin deficiency. So extremely important, has been asked several times in the exams before. Looking at hormonal therapy like tamoxifen, also carrying a risk of type 2 diabetes. So overall, of course, glucocorticoids are used in patients with cancer in different contexts. Especially we are aware of spinal cord compression, then extremely useful for patients with multiple myeloma, lymphoma, those who have a SVC obstruction, graft versus host disease, symptomatic brain metastasis, and many times even to prevent some of the side effects which chemotherapy causes, like nausea, vomiting, and prevention of certain allergic reactions as well. Now, these guidelines particularly intended at management of individuals on supraphysiological doses of glucocorticoids. Here we are talking about this is equal to approximately more than 5 milligram per day of prednisolone. So that will be equal to more than 20 mg of hydrocortisone, and of course more than 4 mg of methylprednisolone, and more than or equal to zero point 0.8 mg of betamethasone and dexamethasone approximately. Again, we should keep in mind the half-life in hours for these, because accordingly then we can plan our diabetic management, especially for hydrocortisone. It has a half-life of 8 hours, whereas when we move on to prednisolone and methylprednisolone, it has a much longer half-life. And when we move on to dexamethasone and methylprednisolone, they have even a more duration for the half-life. This is very important in context of diabetes management, because many times in these cases we need the diabetic management to be arranged twice a day to cover for the hyperglycemia which can occur for the full 24 hours. So this is something which we should keep in mind. There are certain risk factors as well which can cause glucocorticoid induced diabetes. These are obviously patients which may have already pre-existing type 1 and type 2 diabetes, so it may cause further worsening of their hyperglycemia. If a patient just has a family history of diabetes, that is also a risk factor. Obesity, increasing age, certain ethnic minorities, patients who already have pre-diabetes or impaired glucose tolerance or have an HbA1c of 42 to 47 millimole per mole, having a background of PCOS, previous gestational diabetes, previously if they have developed hyperglycemia on steroid therapy, and if the patient is on any concurrent cytotoxic therapy, which can cause hyperglycemia as well. Many a times we notice that this hyperglycemia may or may not resolve even when the glucocorticoids are withdrawn. So I was mentioning to you about my Mastering Endocrinology and Diabetes lecture series. I have now around 90 lectures, which is covering the entire spectrum, which will be helpful for our clinical practice as well as endocrinology exams. There are several sessions on different topics of thyroid, then different topics for adrenal gland. Again, each and every session is case based and oriented to exams and clinical practice. We have around 7 lectures for pituitary. There is a very extensive list of lectures, almost around 26 to 27 on diabetes, covering different guidelines like NICE, JBDS, and even ADA for that matter. Then section and lectures on calcium metabolism and calcium regulation. There are around 15 lectures covering high yield topics for the exams. This includes previous exam recalls, also includes exam lab question and answers, pearls from Oxford Handbook, latest edition, which is the 4th edition. Extremely useful set of lectures for quick exam revision and uh, review. Then lectures on reproductive system, genetic syndromes, lab endocrinology, immune checkpoint inhibitor therapy, and even for that matter, lipid metabolism, covering the latest guidelines as well. So as I mentioned, I mean, of course, the NICE JBDS has been extensively covered. Then I've also covered all the endocrine topics from Endocrine Society guidelines and Society of Endocrinology guidelines. I've also covered the thyroid cancer topics from American Thyroid Association, plus the recent diabetic updates from ADA, including the ADA 2025. Then there are sessions from European Society of Endocrinology guidelines and even ACE for that matter. So all these guidelines are covered in this lecture. So it's not only targeted for one particular section of exams. It is very useful for us for clinical practice and endocrinology exams all over the world. So let's start with the first case scenario dealing with this particular guideline. We have a 68-year-old man with newly diagnosed lymphoma. He started on high dose dexamethasone as a part of his chemotherapy protocol. Now, he is not known to have any history of diabetes. On day 3 of the treatment, he starts to have fatigue and increased thirst. His random plasma glucose has risen up to 14.2 millimole per liter, and on 2 occasions this was checked and it was above 12 millimole per liter. So what is the most approximate next step in the management? Should we start the patient on metformin? Should we start gliclazide 40 mg in the morning and provide a glucose meter to the patient? Should we continue monitoring and reassess in 1 week? Should we start insulin, or should we decrease the dose of dexamethasone? The correct answer as per guidelines is start gliclazide 40 mg in the morning and provide the patient with a glucose meter so that he can monitor his blood sugars and come back to us. Uh, So guidelines suggest that gliclazide 40 mg should be started if the blood glucose is more than or equal to 12 millimole per liter on two occasions, which was the case scenario for this patient. So this is a protocol from the guidelines. Again, this protocol is specifically dealing with patients who don't have a prior history of diabetes. Okay, and those who have started anti-cancer therapy or glucocorticoids as our cancer, as our patients. There is a separate protocol for patients receiving anti-cancer agents or glucocorticoid therapy in patients who are known to have diabetes and already on oral treatment. So in that protocol, they have discussed how will we adjust the oral medications. And there is another protocol for patients who are receiving anti-cancer and glucocorticoids and those patients who are already on insulin treatment. And there they have advised how we are going to adjust their insulins. So we'll be discussing all of these scenarios by case-based approach. So a quick overview, what should be done at the baseline? Check HbA1c and random blood glucose at the baseline. If it is less than 12 millimole per liter, again recheck plasma glucose at each treatment visit. If it continues to be less than 12 millimole per liter, we can discuss cessation of testing and advice to the patient. On the other hand, if the blood glucose is more than 20.1 millimole per liter at the onset, if the patient has got hyperglycemic symptoms, ketonuria or ketonemia, venous bicarbonate is low, less than 15, plus or minus pH is less than 7.3, then we go towards the diagnosis of DKA for that matter. And then even we should then refer the patient to the local accident emergency and start acute treatment accordingly. If that is not the scenario, and if the patient's blood glucose is still more than 20, we have excluded any complications, then we should refer the patient to the diabetes team to start urgent treatment in this case scenario. And of course, make sure that the patient checks his sugars at least 4 times a day. Now, when we are in the process where the blood glucose is more than 12 but less than 20, and we should make sure that we advise the patient to monitor his blood glucose at least 4 times a day. Check for any hyperglycemic symptoms, ketonuria or ketonemia. In this case scenario, which was our patient, we commence gliclazide 40 mg with the breakfast if more than 12 millimole, and also prompt referral to the primary care to initiate treatment. Ensure blood glucose is monitored 4 times per day. Recheck plasma glucose at each visit. In terms of titration of gliclazide, we can go up by 40 milligram increments. The maximum dose for the immediate release gliclazide is around 320 mg per day, with maximum dose can be given in the morning, which is 240, and 80 mg in the evening. And for the modified release, the maximum dose is up to 120 mg per day. Now, many times we notice that, of course, when we give the patients the steroids in the morning, the hyperglycemia peaks around the mid-afternoon to the evening time, and by the next day morning, again, the sugar starts to come down. Hence, the maximum dose is targeted in the morning time. If the patient is getting BD steroids or twice a day steroids or a very long acting steroids, then even we can consider giving gliclazide twice a day. Case scenario 2, where we have a 66-year-old man with neuroendocrine tumor. He's just started recently on a long acting lanreotide. He has past history of diabetes mellitus, which was pretty well controlled and stable on gliclazide. He was intolerant to metformin, and he has been well controlled on the same for the last 10 years. A few days into treatment with lanreotide, he now complains of tremors and sweating before the meals. And when he checked his sugar and couple of occasions at this time, it was noted to be low. It was 3.5 and 3.8 millimole per liter, which is definitely hypoglycemia. He also has a background history of hypertension. However, he's just taking beta blocker for the same. He's recently also started to have episodes of flushing, diarrhea, and bronchospasms. So what is the most likely cause of his symptoms, which is occurring before his meals? Basically, they are asking in context of the hypoglycemia. Is it drug-induced adrenal insufficiency? Is it lanreotide-induced hypoglycemia? Is it diabetic gastroparesis? Or is it beta blocker-induced hypoglycemia? Now, we all know from our initial chart that lanreotide and octreotide both can cause hyperglycemia and lead to development of diabetes. However, when we are talking about in context of neuroendocrine tumor, and if we see the symptom history, this patient was already having some symptoms which are suggestive of carcinoid syndrome. Now, this happens in context of liver metastasis, in which there will be a problem with the hepatic glucose output and subsequently hypoglycemia will happen. And in this context, somatostatin analogs can actually cause paradoxical and refractory hypoglycemia. And that's what's been happening in this particular patient and was the correct answer based on the options provided. Now, moving on to question number 3. Here we have a 59-year-old woman with metastatic melanoma. She is receiving nivolumab. She presents to the ED with nausea, abdominal pain, and drowsiness. Her VBG clearly shows she's acidotic with pH of 7.15, bicarbonate of 12. Blood glucose is high at 22, and she definitely have very high blood ketones at 5 millimole per liter. So, what is the most likely diagnosis? Is it euglycemic DKA? Is it hyperosmolar HSS? Is it ICP-induced DKA? Or is it steroid-induced hyperglycemia? Or is it type 2 diabetes with ketosis? Let's look at the things. So now this is the end of my preview for this particular session. If you like to have access to my full lecture, this particular lecture as well, which has total of 6 case-based scenarios, plus my full lecture series, which I already described in the previous slides, please email me at mazirules@gmail.com or WhatsApp me at 009715574344794. This is a paid subscription, and with a one-time payment, you will get access to all my existing 90 lectures plus all my lectures lifelong. Thank you so much.